Dr. Meghan Mattos is a nursing researcher at the University of Virginia studying shared decision-making, SDM, in dementia care. Her scoping review synthesizes evidence on how persons with dementia can participate in healthcare decisions alongside family and providers. This work is invaluable for families navigating terminal illness because it validates that people with cognitive impairment can reliably communicate their values even as cognition declines. Dr. Matos demonstrates that deliberate SDM preserves dignity, autonomy, and satisfaction for all involved. By developing frameworks for inclusive decision-making across health promotion, end-of-life planning, and housing transitions, her research helps families maintain interconnected relationships while respecting individual preferences through disease progression. Dr. Matos, how was that summary by artificial
Well,
intelligence?
thank you so much, Norman. It sounds like I'm all done. Really, beautiful summary. Beautiful summary. No, that was excellent. I was really curious what would occur when you shared that. Is it all right to get started?
Yes, please.
All right, I'm going to share my screen and just make sure. Can you guys just see the single slide on your end?
No, we see the presenter view.
Of course. It's funny because, of course, we set this up earlier to make sure that this wouldn't happen, but that is absolutely okay. Well, what I'm going to be sharing is about shared decision-making and overview. And as Norman did provide a little bit of background about me, I'm an associate professor at the University of Virginia out of the School of Nursing. And so I'm a nurse scientist. I practiced as a nurse for many years before going back and learning how to do research. So most of my research now is really focused at the individual dyad and triadic level, and I'll go into a lot more detail about that later. But particularly in older adults at risk for dementia, specifically Alzheimer's disease, and trying to prevent cognitive decline. So what I'll be providing is an overview about shared decision making, and a little bit of an introduction, and then I'm going to focus some time discussing an article that I published last year with my fantastic team about shared decision making specifically in dementia. I do have to disclose that this content has been previously published, and this is the citation here. And for each image, if you would like to have the citation, it will be available in the notes that will be published via the website or the platform. So when you guys are done here with me today, my hope is that you'll be able to describe shared decision-making for adults, hopefully a little bit more about living with dementia, but thinking about your own situation as well. You'll be able to summarize the existing research on shared decision-making in dementia that I present. And you'll be able to highlight really the importance of including patients, our family members, and healthcare providers in really a collaborative care to improve patient-centered outcomes. So most of my clinical experiences as a nurse were actually in a hospital setting, working on a general medicine floor and then in a neuroscience intensive care unit. However, when I try and consider some of my personal experiences navigating healthcare and healthcare decisions, I begin to think about a few key moments or situations that decisions are most likely to be reviewed or planned. So one of those is the provider and the patient. This one's pretty common. Oh, so sorry. Another is now introducing, uh-oh. Here we go. Nobody told me. Come on, guys. Excuse me. And then we're introducing a family member or loved one or caretaker into this communicative situation. Another that is common is being kind of talked at by a healthcare provider or an individual, even in the presence of other family members, loved ones, most of the time including the patient, hopefully including the patient. And then the one that I'm most familiar with, and that is the healthcare team itself, talking amongst one another, and then going to the patient, plus or minus the loved one or family member, and sharing with them what they have decided. So overall, what I've experienced is really a lack of open communication amongst all of the parties that should be involved in healthcare decision making. In most cases in the intensive care unit, we only saw one provider relaying information from the healthcare team to a member of the family, for example. What I want to see is really everybody at the table and having a seat from the very beginning. And by the very beginning, I'll be a little more specific later on, but really when symptoms begin to change from what was somebody's baseline or their usual normal symptoms. Since I'm the first one to present, I wanted to just think about some of the healthcare decisions that you have maybe had to make recently that you're thinking about making, just so we can provide some context. I always think it's helpful to kind of follow one decision along the way as we go through some of these examples and the process so that it hits home and really is able to be relatable to you. And so the reason why healthcare and healthcare-related decision-making is vital is that there are so many decisions that must be made, all creating a domino or cascade effect impacting the next decision. And so some of these common healthcare decisions that need to be made include medical treatment choices. These can be whether to begin, continue, or stop medications, whether it's for acute or chronic conditions, deciding on getting surgery or an invasive procedure, and choosing between curative or palliative treatments. Another is preventive and screening decisions. So this could be whether or not to continue cancer screenings, for example, like mammograms, and deciding if and when to be vaccinated. Next is advanced care planning, and I'm obviously very thrilled to see that there is going to be more discussion on this later on, as this is another thing very near and dear to my heart. And this involves things such as advanced directives, so living wills, durable power of attorneys. Things within the hospital that are relevant are what we call do not resuscitate orders, or code status is another item that we need to think about with advanced care planning. And then preferences for end-of-life care. Will we be in the home? Will we be in the hospital? Will we be in a separate hospice setting, for example? Then there are long-term care and living arrangements. So assisted living versus a nursing home, choosing in-home care versus facility-based care. And in the case of older adults, particularly living with dementia, I think a lot about balancing safety, independence, and the capacity of a caregiver to care for somebody 24 hours a day, 7 days a week, many times. Also, decisions related to cognitive and functional assessments. And then one that we cannot leave out, the financial and insurance decisions that must be made. So many times the discussions I have are in understanding Medicare or supplemental insurance coverage and how difficult this can be, whether it is at the local level and what's available, state, national level in terms of the finances and the supports that are available or not available many times. And then finally, being able to knowledgeably choose between treatment options with different costs or different health coverage levels. So just imagine how difficult these already difficult decisions can be, more complicated in light of sensory or cognitive deficits. And so this brings us to shared decision-making and its critical role in healthcare, and the fact that it is many times left out. Simply put, shared decision-making involves collaboration between and among the patient, caregiver and family, and healthcare providers. Most definitions of what I'll refer to as SDM, or shared decision-making, in the US-based studies I've read, also note that patients are truly encouraged to think about available care options, the likely benefits and harms of each of them, communicate preferences, whether that's oral, written, for example, and help select the best course of action that fits these. So with the number of and critical nature of healthcare decisions to be made, using a shared decision-making approach really seeks to incorporate patient preferences and values into healthcare decisions, while also accounting for and incorporating healthcare provider and family, caregiver, loved ones' input. The reason why shared decision-making matters, these are just a couple of bullet points, and I could present an entire hour just on why and how important it is. However, I'm just going to list a couple of those you can put in your back pocket when somebody says, this doesn't really matter. And you can say, actually, it does, and there's research to support this. And so it seems pretty straightforward, but particularly when we have these complicated, many times degenerative or terminal illnesses within our family, whether it's ourself that we're dealing with these or a loved one, the ability to incorporate patient preferences, caregiver concerns, and medical evidence can really be overwhelming and even overridden many times by financial concerns, for example. So in addition for incorporating and respecting patients' wishes and preferences, there are other reasons why decision-making matters, shared decision-making matters amongst multiple individuals of what I would call the patient team. It allows all to manage expectations as you look ahead. It promotes tailored care, and this one is actually very much inclusive of the healthcare providers. And one of the ways in which healthcare providers can really think about tailoring to the individual based on the patient and family needs. It improves satisfaction over and over again for the patient, for the family, and more recent research has showed for healthcare providers as well. It promotes empowerment and control in a situation in which many feel as though they've lost some autonomy. It can boost self-confidence, and this is not only for our patient. This is, or the patient that's dealing with this difficult decision, but also the family, that they're making the right decision. They're communicating amongst this team that's all trying to make the best decision for a person. And then finally, minimizes regret. As I shared, I work in the space with older adults, particularly with early stages of dementia. And this is something that many people will say, I wish we had talked about this sooner. And I think that that feeling of regret and not beginning thinking about every decision as a shared decision-making process is really important. Okay. Is that, oh, sorry, I thought that was my side, excuse me. So for those of you that may not be as familiar with dementia, I want to focus really on shared decision-making specific to dementia, but many of the things I'm going to talk about, I think can translate across different diseases or disorders. What I'm going to do is just define dementia so we're all on the same page. So when I'm talking about dementia, I'm talking specifically about a group of symptoms that include cognitive impairment and an inability to perform activities of daily living. You might say, oh, I have a loved one with dementia. What does it mean when somebody says that they have Alzheimer's disease? Well, this is a type of dementia, but it's the most common type of dementia. And because it's the most common and people come across it more often than other types of dementia, that's the one that's usually spoken about most. What's true for the majority of healthcare decisions is that communication begins to falter or become more difficult when a patient's unable to participate in making decisions or the process in which decisions need to be made. So this can be within a hospital setting, it could be in the home, or it could be in long-term care facilities. As you can see from the definition of dementia, not only does this impact cognitive or our brain health, but also our ability to perform what we call activities of daily living, which include, yes, walking and such, but going to the bathroom, feeding oneself. And so this has a huge impact, as you can imagine, not only on an individual, but that creates a need for help or a caregiver care partner. What's also unique in this patient population is that the brain lesions found in Alzheimer's disease can cause difficulties with memory, language, problem solving, and other cognitive skills, which may also contribute to difficulty communicating by and with people living with dementia. So caregivers and healthcare providers are frequently tasked with making these decisions. And as a result, people living with dementia may experience a loss of individuality and dignity due to this communication barrier. This continues to get worse as the disease progresses many times as well. The Alzheimer's Association does provide a dementia care practice recommendation, and this has a lovely visual with patient-centered care right in the middle, and these guidelines are wonderful and can be used in communication systems to facilitate delivery of care. What it doesn't do is really outline the communication systems or define how shared decision-making is also a part of a communication that needs to be incorporated at not only the patient level, but family level, many times the community level, and obviously with the healthcare team. One challenge to best practice may be that family care partners and healthcare providers also underestimate Alzheimer's patients' desire and ability to participate in making decisions. Another is the lack of standardized tools to promote and actually facilitate shared decision-making and conversations, particularly among the group of older adults living with dementia. Interestingly, and one of my biggest points I hope you take away, there is significant evidence that supports that older adults with cognitive impairment can communicate their values and choices reliably, even as their cognition may decline. Of course, there are going to be challenges, but study after study has shown concordance or similarities between what is said in further cognitive decline, as opposed to prior, what somebody would say, normal cognition said 5 years earlier. And so if we're seeing similarities between those two and opportunities to communicate preferences, needs, desires, they should not be overlooked. One of the ways on the research side of things that I ensure this is anytime I do interviews, the participant with dementia is always present. They may not verbally communicate or participate actively in that interview, but they are there. They are there. And that also allows an opportunity for follow-up. We can watch for visual cues, and there's many other things that are important by just having this individual as a part of the conversation when I'm talking with a caregiver or healthcare team. But they're there. They're there, no matter what they decide to contribute. Unfortunately, adults living with with dementia's decision-making capacity is often overlooked or even revoked by family members or healthcare professionals due to these communication barriers that present with the disease. So based on what was known and is known about shared decision-making in dementia, my team really sought to understand the current state of the science on this topic. And so what we did is we conducted a review to synthesize the existing research on shared decision-making in persons living with dementia. And we identified themes and trends in decision-making practices. And this is what I hope to share with you today. I'd be remiss if I didn't share a little bit about how we did this before I share the results. But what we did is a scoping review, and this involved a systematic search of online databases. We actually looked across PubMed, CINAHL, and Web of Science for those of you that may use some of these databases. We used keywords, dementia, shared decision-making, cooperative decision-making as well. And it took us a long time to find a good, what we call search strategy to capture articles that we thought may be relevant. We only included research with cognitively impaired adults. So this did include early stage cognitive impairment, such as mild cognitive impairment. And we did exclude articles focusing only on healthcare providers. It was shocking to my team how many articles were only looking at one person in this shared decision-making process, and it was the provider. It wasn't that they were looking at the provider leading it. It was only including a perspective of the healthcare provider, which I thought was actually pretty shocking to us. And so what we did is we described, visualized, summarized, and tried to identify categories amongst, as I said, a wonderful team. We ended up screening 263 articles, and at the end, 32 of them met our inclusion criteria. And so these 32 were included in our review article, and that's what I'd like to present to you guys today. We found that 23 studies were from Europe, 7 from North America, which included the United States as well as Canada, and 2 from Australia. Now, as I assume most of us right here are in the US, wow, right? We are not leading the pack in this area. We are really not. There is an extreme lack of evidence in general, but 7 from Canada and the United States. On top of that, most of these studies were qualitative in nature. And when I say that, simply it's lower levels of evidence were published on this topic. There were 21 that were qualitative, and then there were 11 that were quantitative, including 1 randomized control trial, which is really considered our gold standard when we're conducting research. 4 categories emerged from review of these articles, of a team of 5 individuals, I should note, all from different backgrounds. We had sociology, nursing, we had a librarian who was really a huge asset, not only with the search, but in trying to understand and make sense of some of the things that we found. And so the 4 categories that emerged on the available literature were health promotion, end-of-life planning, decision-making tools, and housing decisions. For those of you that are new to this space, you might say, oh, interesting. For those of you that are not, you might say, yes, obviously. That's not necessarily surprising. Oops. So I'm going to go one by one and provide a little bit more detail about what I mean by health promotion. We found that 11 studies examined shared decision-making in various health-related contexts, and we put this under the category of health promotion. So these included general patient care, activities of daily living, clinical appointments, and medication use. So earlier I spoke about getting assessments, for example. Those fell into the clinical appointments area focus. What was really interesting about these is that although across 4 different health promotion areas, patients across the board showed dissatisfaction when not given choices. Again, this would be expected. We would think that to be the case, but to have it documented is truly one of the first most important steps as we think about how to promote and improve what we already have in place. When using shared decision-making approaches, in other words, incorporating multiple members of the team, allowing a voice and opportunities to communicate with and amongst one another, oh my gosh, improved adherence and satisfaction. So again, these are all wonderful things to have found in the literature. What was interesting was that there were differences in the approach to incorporating shared decision-making as we look across dementia severity. So for example, those that may have mild cognitive impairment and later stage Alzheimer's disease. The second theme was advanced care planning, and 6 studies examined shared decision-making, looking really at the end of life as well as long-term care planning. It focused primarily on the importance of consensus building among caregivers in particular. It spoke a lot about the ethical concerns regarding decision-making. The majority of these really revolved around the inability of older adults living with dementia's ability to communicate further into or later stages of Alzheimer's disease or other dementias, and the lack of knowing where they stood earlier on to be able to feel that caregivers or healthcare providers were trying to promote the patient's best interests through the patient's preferences, views, and values. Also focused a lot on the emotional well-being of the family. When we talk about things like end of life and long-term care planning, it is complicated, it is complex, and it is rare that everybody is on the same page with that first conversation. And as we found with the first category, shared decision-making increased acceptance of dementia diagnosis, so there was a positive with this, and even promoted future care planning, which was wonderful to see. We did not expect housing and daycare decisions to kind of rise to the top as its own independent theme, to be honest with you. But there were, did I skip it again? I'm so sorry. But there were a total of 5 articles that went into great detail. So I'd like to focus on the 4 that talked about the shared decision-making process when making decisions regarding housing or home placement. And so the caregivers were playing central roles in this decision-making process. What was not clear was at what stage they were making these decisions and if the patient's preferences were incorporated. The second is that higher caregiver burden. So when a caregiver reports difficulty, overwhelm, even some medical concerns that are arising, whether it's stress in taking care of somebody else, when these are higher, it's linked to more active shared decision making. And so it was interesting that this was noted in 2 of the articles specifically. Obviously, there needs to be more work done in this space to see if there's a direct relationship. In other words, higher caregiver burden impacts or is directly related to active decision making, but still really interesting to think about. Patients prefer to stay home as long as possible. And really, there's a need for these shared decision-making interventions to support housing transitions. In other words, some sort of framework, script to begin to talk about the decisions, to understand the different options available. There was also one study on the use of shared decision-making in the use of daycare. And when I'm speaking about daycare, it is the opportunity for adults living with cognitive impairment to have caregivers to have respite, and adults living with dementia an opportunity to come within a group of individuals and outside of the home. Typically during typical work hours, whether it's for 1 hour or a whole day, it's not that they sit all day and don't do anything. It's they are actively engaged in different opportunities for whether it's cognitive enhancement or socialization. And in this case, really initial expectations influence decisions more than anything else, which speaks to the fact that it would be more potentially more difficult to use shared decision making in this context for daycare as opposed to looking at housing. And when I say patients have less autonomy in major decisions compared to daily choices, this is that the patient or the person living with dementia may not have been given the opportunity to decide yes, no to daycare, but once in that situation, they were given opportunity to make choices as to what activities they would engage in. And then finally, there's the development of decision-making tools. And this is really, I think, one of the most important pieces when we think about next steps. And I know the next presenter, I'm really looking forward to hearing some of her work in this space. And so we found that there were 8 studies that examined formal shared decision-making tools. These were overall decision aids that patients could use, written form, caregiver-oriented tools, which were not only scripts. These were in a couple of different forms, and many times were in this dyadic format, wherein there were pieces of it that were geared toward the patient or the loved one with dementia, and then the caregiver, but it was on this shared piece of paper, which sounds silly, but it's somewhere to start when you're saying both of these perspectives are important and are shared in one document. And then, of course, the shared decision-making models for providers. And I do not mean to speak about this in a negative way. I think that it's just very, very challenging and has to be approached in a lot of different ways. And so making sure to incorporate providers is vital, but I still put the patient at the center of these decisions. And so the number of articles that I shared focusing on providers is concerning to me within this space. Overall, all the findings suggest, though, that these tools improve communication and decision confidence for the patient, the caregiver, as well as providers. I'd be remiss without saying there are obviously going to be some limitations to any research study. We did find that there were relatively small sample sizes and variability in study inclusion, and this really limits our generalizability of the current shared decision-making tools that we have. In other words, rural versus urban populations across different racial or ethnic groups, even different cognitive status, cognitive impairment levels. There's also a lack of standardized, validated, that means really well-tested, SDM tools that were used in these studies. And so there needs to be significantly more work done there, and limited to no use in real-world clinical settings to see if these are helpful in making a decision that an action was taken. The decision influence an action that was taken. In summary, everything from that study, I would say healthcare providers should still actively involve patients in shared decision-making, remembering that they're at the center and they're at the core, and healthcare providers are there to provide incredibly important medical expertise and guidance along the way. We need evidence-based tools and training to really have effective implementation, particularly in these older adults with dementia, but based on my limited understanding across many, many other patient populations as well. It's also possible to start shared decision-making within a family by establishing open communication, holding regular family meetings to discuss plans, concerns, and make sure to involve, I say everyone with an asterisk, which I'll come back to, in the decision-making process to try and ensure that everyone's voice is heard. And so I say everyone when it is the choice of everyone that the patient would like to be involved. That doesn't mean every single cousin, nephew, great godchild. And it's really important that if possible, it's the patient that's deciding who's on their team. Some of the current research trends, so where we're going, trying to think positive and hopeful about next steps. There are more studies that are focusing on shared decision-making topics that include things such as health promotion, end-of-life care, and advanced care planning, and they are increasing in number in the United States that are being published. There continues to be an emphasis on developing tools and frameworks, in other words, ways to describe different variables or factors that may impact the ability to promote, to conduct shared decision-making approaches or processes and have a positive end result. And when I say positive end result, I mean everybody feels as though they were heard, the patient's wishes were respected. And then there are legislative efforts, at least in the space of adults living with dementia, to focus on patients' right to participate in decisions across this cognitive health timeline. So this is my last 3 points that I want to really stress, that if I lost you for a couple of minutes along the way, please, please, please note research suggests that shared decision-making improves patient and caregiver satisfaction across the board. Shared decision-making does require deliberate effort from caregivers as well as healthcare providers in order for this to be successful, because we're discussing healthcare decisions in particular. And it's necessary that healthcare providers receive training in ways to promote shared decision-making techniques, because again, these are focused on healthcare decisions, and many times are going to start from something that is shared or a change in medical status that is presented or assessed by a healthcare provider. So thank you so much for your time and attention. I believe we have 5-10 minutes, and I'd love to hear some of your questions or concerns.
I'm
Kim.
going to hand it off
Or
to Kim Kasaya.
You got it. So, one question, how can families initiate these conversations with the shared decision-making conversations without overwhelming our person with living with dementia, especially when there's those ebb and flows with the cognitive ability?
So it's incredibly difficult, and I was actually thrilled to hear kind of your background. So this is something that I'm sure you run into daily. I can say, well, it's best when we catch them early in the disease process, obviously, because it's easier to communicate. The family members may feel more confident in what is being communicated to them by their loved one. But I would say we try and do it multiple times to see if the response is the same. We do not try and overwhelm. If one person bringing that up, for example, if a family member or loved one is discussing it and asking these questions, and that is a no-go for our patient, then maybe the healthcare provider initiating with, just in the first picture I showed, with the loved one off to the side. So it's kind of the healthcare provider patient conversation, but somebody else is present, try somebody different, and then look back on other decisions that were made in the past. Is what being said consistent with what multiple people in the family believe? You know, how many times do you run into a spouse saying, well, this is what they would have wanted, and a sibling saying, that is absolutely not what they wanted? And you take a step back and say, okay, what is the best way to do this? And it's unique for each individual, but if we can try and promote communication, if we actually ask the question, my experience has been extremely positive in that if it's a head nod, a head shake, and consistency in answers, you're going to feel more confident as a loved one and not have some of those feelings of regret or blame placed on you for making a decision that may not have felt informed.
Nice. Very much so. Now, what are some strategies to resolve some of the conflicts between family members that they have different ideas or different plans for their person? What are some strategies what are some ideas?
So within the hospital setting, there are typically ethical consults, they're called, where somebody can come in and have this conversation with multiple members of the family. Sometimes it will actually be in the patient room with the patient present if possible, but sometimes, especially in cases of dementia, they are not included and it's in a separate room. And so inpatient setting, ethical consultations are possible. Sometimes there's a manager or a person that has experience trying to, depending on the situation, diffuse or collect different perspectives to make the most educated decision. So really in this more objective position from afar, I think where it's most difficult is particularly when primary care providers share what I call big diagnoses with limited information. So it is very clear this individual has some sort of cognitive decline and now they're unable to bathe themselves independently. This is now a dementia diagnosis. When you have more information about what the next steps may be, what is coming down the line, or potentially not always with a nice timeline, unfortunately, but at least things to prepare for, these conversations are much easier. And so as you can imagine, with these big diagnoses without support, that's when it breaks down. And that's where I think the primary care providers can't do it all themselves, that there are needs for specialists, whether it's neurologists, neuropsychologists, memory clinics that are able to support not only decision making, but provide the options, the therapies, the next steps. Because although these decisions are, so important, you have to know as much as you possibly can in your unique situation. So I work a lot with rural adults, for example, rural older adults with dementia. Those conversations are very, very different than I have if I am in our memory care clinic with a family member, a caregiver who always attends. This is their 4th year in a row coming annually, no problem. It's just different. And so I don't have a universal right answer, but my hope is more information, appropriate referrals to learn that information, and starting to bring, especially in dementia, starting to bring a loved one, a care partner along. So there's somebody else present during these discussions. And I know I do this with my parents at this point, I don't have concerns for cognitive impairment, but I still go to most of their appointments just to make sure we're both hearing the same thing.
Exactly. Being on that same page. And we are all individual, and it's sometimes can be so different. Let's see.
So
here.
I want to thank you, Megan, for if anyone has any questions, feel free to join the online community, and we will, Megan has already joined, so that's great. And I want to hand that over to Norman for our closing so that we have a little bit of a break before our next presenter.
Thank you so much, Angela, and thank you, Kim. Megan, thank you very much for your presentation. The bit that I loved was just this one slide where you showed all the stakeholders at the table talking with each other. Now, I have been trying to envision how I could get them together in a virtual table where they're actually talking on digital ways and in a somewhat of a network. Now, have you seen this actually done or been possible in other environments where healthcare providers actually gather around the same table with a family, talking about the specific shared decision-making case?
Sorry, physically or digitally?
Digitally, yes.
So no, not digitally. I know that there's a lot of difficulty in taking turns in that setting. A lot of my work is behavioral interventions via the internet, which is the only reason I can speak to that. But at least in some diabetes management, there is typically an opportunity for multiple people to access a platform, which means if a physician is talking with a patient, in some cases a child, type 1 diabetes, obviously the parent is going to be involved. But let's say it's an adult and they have uncontrolled type 2 diabetes. Having this care partner on the same platform able to share, well, this is going on. And again, full transparency. This isn't one person, trying to triangulate. This is one person sharing. This was what I was noticing. This is the patient saying, well, actually, when I took my blood glucose, it was this, and they weren't there when I did that. And then a healthcare provider being able to chime in, but it's not in real time. Right? It's not going to be this continuous flow of conversation that we would have around a table.
Thank you so much, Megan. You basically just shared with us how we could possibly make this happen digitally. And that's what we're trying to do in our community. So I'm sharing the link. Please join our community so that we can at least have these discussions or try to have them. And thank you again, Megan, for your presentation. We're looking forward to our next presentation.